Good afternoon, guys. I have discussion A for you. Now we're discussing medicine's identity crisis when health means everything. Okay? So give me a second and we'll get going on the show for now. On a great Tuesday morning in Northwest Pennsylvania, the hospital feels like a living organism. Monitors blinking, stretchers rolling, the low hum of fluorescent lights setting over everything. In the emergency department, a nurse is triaging a man with chest pain while simultaneously completing a mandatory loneliness screen. Down the hall, a care manager is trying to arrange transportation for a patient whose discharge is delayed not by medical instability, but by the absence of a ride home. Upstairs, a physician is toggling between medication reallocation and a housing referral portal. None of these tasks are inherently wrong. In fact, each reflects a truth clinicians have known for decades. Health is shaped by far more than biology, but taken together, they reveal something deeper and more disorientating. A system that has stretched the definition of health so wide that medicine no longer knows where its border lies. This this is the quiet identity crisis unfolding inside American healthcare, not a crisis of or compliance, but a scope, not a failure of compassion, but a failure of boundaries. The day medicine became responsible for everything. This is a moment. Ask any clinician when a job changed. It didn't happen with a single policy or a single reform. It happened gradually, almost imperceptibly, as the world health began absorbing everything around it. Loneliness became a health issue. Housing became a health issue. Climate became a health issue. Productivity became a health issue. Happiness became a health issue. And once everything became a health issue, Medicine became responsible for everything. Clinicians felt it first. They were asked to screen for social needs, document them, fix them, and be accountable for outcomes they could not control. They were asked to be clinicians, social workers, therapists, housing navigators, dietitians, life coaches, and community organizers, often in the same visit. Patients felt it too. They were told that their health depended on endless vigilance and self optimization. Health became a performance, illness became a personal failure. Policymakers felt it most accurately. If health includes every social condition, then every social condition becomes a medical budget line. The system becomes financially unsustainable because it conceptually unbounded a woman at the edge of the system. Consider 82-year-old woman living alone in rural Pennsylvania. Her heart failure stable, but her life is fragile. The driveway ices over in winter. The nearest grocery store is 20 miles away. Her children live out of state. Her home leans slightly to one side, the foundation settling after decades of freeze thaw cycles. Her clinicians know all of this. They know her health is braided tightly with her circumstances. They know her loneliness worsens, her symptoms, her transportation barriers limit her care, and her home environment shapes her safety, but they also know the limits of their reach. They can adjust her diuretics. They can listen to her fears. They can help her plan for the future. They can accompany her through the uncertainty of illness. What they cannot do is rebuild her home, redesign her town, or reverse decades of economic decline. Yet the system insists they try. This is the paradox at the heart of medicine's identity crisis. We have expanded the definition of health so far outward that the clinical center is dissolving. How health became a catch all. The forces behind this expansion are complex, but three stand out: social detriments. Evidence made it possible to ignore the upstream drivers of illness, but instead of partnering with sectors built to address them, healthcare absorbed them. With wellness culture, a 1.8 trillion industry blurred the line between medical care and lifestyle aspiration. Health, health became a brand, not a biological state. Value-based incentives, payment models rewarded systems for chasing broad populations, health matrix, even when they had little to do with clinical care. The result is a health system that promises to fix structural poverty with care coordinators, reverse loneliness with apps, and solve chronic disease with motivational texts, messages. It keeps expanding its responsibilities while shrinking its ability to deliver on them. The emotional cost of trying to be everywhere or everything. In interviews across the country, clinicians describe a similar feeling: moral injury, not burnout, though burnout is real, but the deeper ache of being asked to solve problems that are fundamentally political, economic, or environmental. A primary care doctor in Ohio describes spending more time on housing forms than on hypertension management. A nurse in Arizona describes documenting food insecurity in a chart she knows will not change the patient's pantry. A palliative care physician in Pennsylvania describes the heartbreak of watching families navigate not just illness but the entire architecture of a life that has become precarious. Medicine has become the default system for every unmet need. It has become the place where society sends the unsolved problems. But medicine was never designed to be a substitute for housing policy, economic development, or community infrastructure. It was designed to care for the sick, support the dying, and accompany people through the hardest moments of their lives. When we ask it to do everything, we weaken its ability to do everything well. What medicine must reclaim the path forward is not to retreat from social contexts. It is to reclaim medicine's identity within it. Medicine must remember what it is uniquely built to do: diagnose, treat, comfort, and accompany, heal. It must partner with other sectors rather than absorb them. It must honor the dignity of patients without turning health into a moral scorecard. Three principles can anchor a healthier identity: clinical clarity. Medicine should focus on what it does best, caring for people through illness. Intersector partnerships. Health systems should collaborate with housing, education, transportation, and social services, not replace them. Human dignity. Health should not be measured, be a measure of personal value. It should be a shared human condition. Health does not need to mean everything. It needs to mean enough. Enough to guide care. Enough to anchor responsibility. Enough to allow clinicians to practice without drowning. Enough to let patients be human without being judged. Let medicine be medicine again. Thanks, guys. That is A for you. I will be back on shortly with B. Give me a bit, please, and I'll have that for you. For now, Gator Wellness. Take care, folks.